Good afternoon, doctor. Good afternoon, everybody. My name is Hai Liang. I am the organizer and also the moderator for this session today. Today we have Dr. Suniza, breast surgeon from UMMC and also a lecturer. I haven't had the chance of being tutored by Dr. Suniza, but from what I've heard, only good things lah. Okay, so can we have the next slide?
Are you sure good thing?
Yeah, yeah, very good.
Thank you.
All describe you like an angel.
Seriously.
Yeah, that's why everyone been asking about why Dr. Suniza? Oh, she's very good. How did you get her?
Okay, now I have to be an angel. Can you see my wings at the back? Okay.
Yeah. So just like thank Noreen for inviting you lah.
Sure.
Okay. So today we'll be talking about breast tumors and other breast conditions. So next. Okay, so before we just go on, maybe I just like to go over some anatomy of the breast. Uh, so, so just a warm up lah. Doctor, what do you think is the most important part in the breast when it regards to surgery?
Okay. You can see from this slideshow, you already know how the breast been developed to, right? So it's basically when you do a surgery or during a clinical setting, these are the structure that you need to see, and anatomy is very very important. If you don't know the anatomy, so you won't be able to cut. You have to know the plane, you have to know where to cut, you have to know the plane in between muscle and skin, muscle and breast tissue, the breast tissue with the skin, yeah. So as you can see, you want me to describe the anatomy or you want to continue?
Just briefly lah, no need to go into so detail. Just like to ask, so I've been reading up on the breast. So I just identified a few things that I like you to confirm or deny. So from what I've read, the breast cancer can occur in the axillary tail. Is that a high prevalence thing or is it not that true?
All right. The axillary tail, can you see from the structure here itself? Your breast is extend toward the axilla.
Yeah.
So your breast tissue extend towards the axilla. It means that anywhere is within the breast tissue, there is a risk of you might develop breast lump, breast cancer, or anything. Okay. Even if you have an accessory breast is actually in the axilla. I'm sorry, who's the? It's a bit disturbing. Who is on the? Can you mute the? No. Yeah. Thank you. Okay. So anywhere. Okay, anywhere in the breast tissue. So how your breast tissue? How do you know where to examine your breast? It's basically it been divided. You can see the breast extend towards medially into the where exactly? One finger breadth from your sternum. Okay.
Yeah.
Inferiorly is your
the sixth rib, is it?
It's a inferior mammary border. You can see when the breast develop, you can see the inframammary. That is the line actually. Inframammary. Okay, because 6 ribs you have to count. Okay, but when you look at the breast, how do you know the breast is top at the inferior border is at the inframammary? Okay, inframammary border. And laterally, you go to the anterior axillary line, and superiorly at the second intercostal, or you can say that you can see up to your infraclavicular, because in the infraclavicular you also have a lymph nodes, right? That might be related or might not be related with your breast tissue or breast lump or breast cancer. So anywhere within this area, so you have to check on the the possibility of breast cancer to occur is there.
Okay, so second thing, just like to know. So from what I've read is that the breast shape is maintained by the ligaments of Cooper. So
Mhm.
during the surgery, like for example, a breast mastectomy or trying to reconstruct the breast, do we remove the ligaments of Cooper or do we just cut through it?
We don't, I mean, during surgery, you don't really need to identify the Cooper ligament. So basically, you can see during the surgery, but don't really like identify and preserve it. No, we normally just cut it at the area of the interest area that you want to cut. Yeah.
I see. Okay, so just the last thing about anatomy. So from what I've read is that 85% of the lymph drainage from the breast is going to the axillary lymph nodes, and about 15 no the rest would be going to the internal mammary lymph nodes. So just like to know, is this true, or all of them just go to the axillary lymph nodes?
Okay, remember when we talk about if a patient has a breast cancer on the right side, there is a risk of patient might develop a contralateral site. Because why? Because there is the internal memory nodes there that might communicate in between the right side to the left side. That is why there is internal memory nodes as well. You know, the cancer can spread through that also. Okay, but in surgery you can't really remove all this because it's inside your uh, thoracic, so we can't do that. Means it we can only control with the systemic treatment, for example, like chemotherapy or hormonal therapy.
I see. Okay, so that's the warm up per se. So for the anatomy, so now can we move on to the next slide?
Mm-hmm.
So this table I've gotten from Browse. So these are lists of the what do you call that? A list of the diseases, disorders that plague the breast. So so for just like to know, so from what I've read is that the nomenclature current nomenclature of the breast carcinoma is divided into the ductal and the lobular. So is it important for us to distinguish between these two types of cancer?
Uh, the it is very important because the ductal carcinoma versus lobular carcinoma, they present differently.
Mm,
I mean, most of them will present with breast lump, but sometimes for the lobular carcinoma, they may present differently. The lump sometimes is a little bit vague, it a bit difficult to identify in lobular carcinoma as compared to ductal carcinoma.
mm-hmm.
So, and the grade, the type is cancer is very important, is as for us to guide us in terms of a treatment later.
I see. So for example, in a ductal carcinoma, what would be done differently in comparison?
Okay, for the the treatment is almost the same, but you have to bear in mind that in lobular carcinoma, most of not I wouldn't say it's most of the time, but they can present bilaterally. That's this important thing about the lobular carcinoma. So in a lobular carcinoma, as unlike the ductal carcinoma, they present differently. One thing is they can present bilaterally.
Mm-hmm.
That is why sometimes in a case of very young patient with a lobular carcinoma, I would probably do MRI, which is very rare. You see that I request for MRI, but specifically in lobular carcinoma, I have to bear in my mind that the lobular carcinoma can also have in the contralateral side. I mean, it's bilateral. That's why it's very important for me to look at it. And lobular carcinoma also is not that I would say the
Not that
response,
common.
yeah,
Oh,
it's not that common, and the response towards chemo differently towards ductal carcinoma. I mean that the ERPR status, HER2 status is different compared to lobular carcinoma.
mm-hmm.
Ductal carcinoma.
Okay. So this is the malignant breast conditions, basically just breast cancer. different types of breast cancer. So from what we see from this table, there's a lot of benign breast conditions. So this is what I read from Baylis and Love. So they describe, they have a section for, they have a new nomenclature for benign breast conditions. It's called aberration of normal development and involution of the breast. Do we use that nomenclature here in Malaysia, or is that not a thing?
Actually, it's just a nomenclature, like but normally we call it as what the tumor is. It is, for example, like fibroadenoma, fibroadenosis. It's good to know because it easily can be classified into, so you can understand why it has been divided like that. But it's, as I said, it's easily to divide your benign breast lesion into this, rather than I would say. But most of the time, when you give a differential diagnosis, you won't say that is a aberration of normal blah blah blah, right? You will say that my differential diagnosis would be fibroadenoma. Those kind of thing that you should know lah.
I see. So one last thing about the benign conditions, yeah. So from what I've read is that a breast cyst can present as a discrete lump, but a fibroadenoma can also present something like that. What would be your go-to method to differentiate between these two, doctor?
Okay, I just give you a very simple, for you to memorize all these things. Okay, so most of the time when the patient come to the hospital because of breast lump, you just remember that 1/3 of this lump is cancer, others is benign. So, but you should have rule out all these another 2/3 not to become a cancer. If you miss a cancer, it's very bad for you, right? So, but how you differentiate it? Because most of the time they will present with a lump. Okay, so the lump, as you said, can be painful, can be painless, but you cannot say that if it's painful is unlikely to be cancer. No, that's why if a patient has symptoms, you should go into 3 things. What are the 3 things that you learn?
You mean symptom-wise, or?
No, to confirm it, you have to do
the triple assessment.
Correct. So these are the things that to differentiate all this. By just clinical judgment, it means like I can feel a lump, okay? But if it's just a lump, you can't really tell whether this is a cancer or not cancer. But if there is a malignant features, for example, what are the malignant features that you know of?
Microcalcification.
I mean, by looking at the breast, you know that this is most likely a cancer.
Skin changes, nipple retraction.
Correct. So if there is these features, then you might probably say that, okay, this is most likely cancer. Okay, but it's just a lump. You can't really rule out whether this is a cancer or non-cancer. So what you should do is you should complete your triple assessment. That is take-home message, I think. Too early, but you have to remember triple assessment is important in breast cases.
So just to summarize what triple assessment is, in case there are people here who don't know what triple assessment is. So it's a history examination, investigation, and biopsy. Am I right?
No. Okay. It's very easy. You can divide it in clinical, okay, radiological, and then your pathological or histopathology. So your clinical can be divided into your history taking and as well as your physical examination. So you, as I said, you cannot rule out carcinoma just with this one clinical component. Cannot. So you should proceed with your radiological. So what are the radiological that you know of?
Ultrasound, mammogram.
Ultrasound and also mammogram. Okay. So these 2 things, and then you proceed with your biopsy, which is your histopathology lah. It can be fine needle aspiration, you can be excisional biopsy, incisional biopsy, core needle biopsy. Okay, so these are the three things that you can, about the triple assessment.
I see. Okay, so let's just go into the cases that we have today. So the next slide. Okay, so just like to read the prompt. So Miss Latifa, a 66-year-old Malay female, admitted to the hospital with a 7-month history of a lump in her left breast. So these are the differential diagnoses as we stated before. So let's just move on. Yeah.
Before that, can
Oh.
you go back to your slide? Okay. You can put fibroadenoma, but normally fibroadenoma you can maybe put a little bit lower down, because fibroadenoma at the age of 66-year-old is very uncommon, right? Because you said that when you aberration of your undi is fibroadenoma is during the hormonal changes. At the 66-year-old, most of the patient is already menopause.
I see. So when you see an elderly woman with a lump, you would think about the breast cancer?
Yes, the most important thing is you have to rule out your breast cancer. Okay, so but fibroadenoma you can have your differential diagnosis, but it's at the bottom, not at your third differential. You can say you can have for example, like phylloides, that can be one of your differential diagnoses.
I see. Okay, thank you, doctor. So let's just move on. Okay, so this is the history of presenting illness. So about 7 months ago, the patient incidentally found a lump in the left breast. It's irregular in shape and progressively increasing in size over 3 months. Otherwise, there were no pain, no skin changes, no itchiness, no nipple discharge. Subsequently, she went to a nearby clinic and referred to Hospital Terengganu. The lump was investigated with ultrasound and a mammogram, and the diagnosis of breast cancer is reached. A core biopsy was done 3 months ago and diagnosed with ductal carcinoma. So anything you want to add here, doctor?
What do you think? Do you think enough the history? Or I think you have some more history. Like for history presenting illness, I think it's enough. You have a duration and you have all the symptoms that associated with the breast lump. What are the things that you think that might need to add on in your history of presenting illness for the current presentation?
I think maybe can add the size and the shape and such.
Patient can't really tell you about the size. Other symptoms.
Oh, okay.
That
So
might
like,
related.
so like the loss of weight, loss of appetite, is it?
Correct. So that can help you in terms of whether this is maybe a cancer or maybe not a cancer, or maybe if it's cancer, so it means that it's already metastasis. So it alert you by going through the history. So for example, like patient came with breast lump and also back pain. So you worried that, maybe possible the breast cancer already matched to the spine. Yeah. So those are the things that never miss in your history of presenting illness.
I see. Okay, so all of this should be in the history of presenting illness, yes?
Correct. So you should mention in the history of presenting illness all the metastasis symptoms, okay, and your constitutional symptoms as well, loss of weight, loss of appetite. Okay.
Okay, so let's just move on to the next slide. Okay, so here just a brief thing lah. Systemic review is negative. So appropriately, we should have involved all the relevant negatives in the HOPI.
Correct.
Yeah. Okay, so just moving on. The systemic review is insignificant. The patient has a past medical history of hypertension that first diagnosed in 2006, and also diabetes mellitus diagnosed in 2016. Currently on subcutaneous insulin, the HbA1c is about 6%. Negative past surgical history, drug history. The patient takes 20 units of subcutaneous insulin per day. No known drug allergy or food allergy. No family history of cancer. Next slide. Next slide. Okay. Gynecological history, menarche at age 12, menopause 12 years ago at 55. Obstetric history with 4 children, attempted breastfeeding for at least 3 months for all children. Social history would be that not smoking, not didn't drink alcohol, lived with her family in Terengganu, works as a housewife. So from all this miscellaneous history, there are, of course, a few risk factors that we need to ask about. Yes, doctor?
Yeah.
Yeah, I'm just asking if these risk factors have been covered sufficiently in the miscellaneous history.
What do you think? Obviously, it's not enough, right?
Mm-hmm.
So what are the things that you think? You say that risk factor, right? So risk factor is a must to when you ask the patient. It's a must. Every each single risk factor you cannot miss. Okay, what are the things that you think that might miss here for your risk factor?
Uh, Drug history, whether or not the patient is taking estrogen.
Mm-hmm. Estrogen as
Hormonal replacement therapy.
correct. Hormonal replacement therapy. As you said, that patient is already menopause at the age of
55.
50, 55.
Yeah.
So you should ask whether this patient, whether she ever take any hormone replacement therapy after menopause or premenopausal, you know.
Mm-hmm.
What else? Which in relate with your estrogen medication?
I'm not sure, doctor.
Your oral contraceptive pill, is it important?
But the
Yeah.
patient is already menopause, so I would think that maybe that's not that important.
Okay. When you talk about risk factor, it means that any time during her life, during the whole life, it means that even the before also, you also need to know. Because what? Because you want to know how long this patient been exposed with estrogen. Okay. The longer the patient exposed to estrogen, the higher chance she might develop, not she might develop, she has a risk of developing a breast cancer.
Mm-hmm.
That's why you need to know early menarche, late menopause, right? So why should I need to know about this early menarche, late menopause? Because when you had early menarche and late menopause, it means that that is the duration where the patient has, her life exposed towards the estrogen. Okay, and then some more you add on with OCP, you add on with HRT, you know. So these are the things very important when you ask about it. Okay, and when you ask about the estrogen, OCP, you have to know whether how long the patient take it. She, for example, like she has 4 children, so every each children, how long she took the OCP, for example. For let's say the first child, after the first child she took like 2 years, then subsequently get a second child, third child, and then you calculate and almost like about 6 years. So anything beyond 5 years, the risk is higher compared to just 1 year, 2 year. You know, that's why you really need to calculate every each year. So the cumulative years is the more important thing that I would like to hear from your history.
I see.
Mm.
Okay. Li Yixing asked radiation exposure.
Radiation exposure, if it's significant, you can also say that whether radiation exposure is not only is not like chest X-ray. Everyone has this chest X-ray exposure. Anything that related with radiotherapy, for example, yeah. Okay, you can include in your risk factor.
Okay. So, is there anything you'd like to add, doctor?
Of course. How about the family history?
Family history is not no family history of malignancies.
Okay, no family history of malignancy. Okay, in your family history, when you ask the patient, how do you specifically ask for the if you want to rule out a breast cancer? Breast cancer related. For example, like in BRCA1, BRCA2, how do you normally ask the patient?
So
you have to be very specific, right?
So need to ask about ovarian cancer, whether any family history of hysterectomy, maybe.
Okay, so normally you have to know in like this patient, she has no family history of breast cancer. So, but you have to really clarify with the patient, is there any like her mom, her sister, grandmother, grandfather? Okay, it's on not only the maternal side, you also need to know about the paternal side as well. Both will give a risk of developing breast cancer. Okay, so the most important thing is the first degree and second degree. Means that the sister is a first degree, mom's first degree, kids first degree. Second degree could be your aunties, uncle, your grandmother, your grandfather, you know. So you have to ask in detail. Okay, and you said just now over either related with ovarian cancer or breast cancer. So these are two cancer that is important. Okay, but other than that, it can include your sarcoma, leukemia in TP53 or in prostate cancer, you know. So you should ask in detail what type of cancer and what else. If they said, okay, I have brother with sister with a breast cancer. So what are the history that you need to know in order to know whether this is related or might not related with the genetic predisposing?
Maybe how old the patient was, how old the family member was.
Correct. So when the patient when is the sister been diagnosed? Not the sister pass away. When the sister pass away, no. Is the when the sister been diagnosed. The earlier the diagnosis, the higher risk of patient. The patient might develop because of the genetic.
I see.
Okay.
Okay. Yeah. So if there's nothing, we can move on.
Okay. What else? Yeah. I think that's all.
Okay, so let's just move on. So these are the risk factors that we already mentioned previously. So let's just move on. Okay, so this is the examination. So just like to read to you. So general examination is quite normal, comfortable, think of air, not in respiratory distress. Vital signs is 64 beats per minute for the pulse. Respiratory rate is about 20 breaths per minute. A bit borderline tachy, but not yet. Okay, so the breath examination.
Sorry, tachy. Yeah. Tachypneic or tachycardic you're talking about?
Tachypneic, not tachycardic. Yeah, it's borderline more one breath than it would be considered.
Okay.
Yeah. Okay, so for the breast examination, upon inspection, the breasts are symmetrical in size, no obvious scars, no obvious skin discoloration, no nipple discharge, no depression of the nipple, no observable movement when the pectoralis major is contracted. So, doctor, for the inspection stage, do you think this is enough for me to say, or do I need to add more?
All right. So I think when you inspect the patient, you have to do all this one, right? What do you call that?
Peripheral examination.
Yeah, peripheral examination, because this is very important. But now we are talking about breast examination. When you talk about breast examination, when you observe, you should. I think you already done a contraction, but have during the inspection as well, you should ask the patient to lift up the hands. Why it's so important when you ask the patient to lift up the hand? Because one thing is you want to look at the patient axilla as well. Don't forget. Just now you asked, right, whether possible the breast cancer can develop in axilla. It can develop in axillary tail, and as well as it can also present as a lump in the axilla. So that's why it's very important for you to ask the patient to lift up the hand, and then if hands doesn't show, on the you can see in the axilla there's nothing can be seen, or no changes or anything, then you ask the patient to contract the pectoralis major. Okay, so yes.
Okay. So moving on to palpation. So for the right breast, it's normal, no tenderness, no lump noted. For the left breast, there was a lump noted in the upper inner quadrant, measuring about 2 centimeters by 5 centimeters. It's firm in consistency, fixed when moved vertically but not horizontally. no nipple discharge can be expressed. So this obviously is not quite enough for the infection of the lump. So doctor, can you just add on what do you think would be necessary for this case?
Okay, when you, I think you covered almost. Okay, when you palpate, okay, before you start or you do inspection whatever, you should have your what call that, patient position. So when you do inspection, patient have to be sit up.
Yeah.
If a patient is comfortable, you ask the patient to sit up at the edge of the bed, and then now you're going to palpation. How you palpate is normally, I would prefer you to ask the patient to lie down. When a patient lie down with one pillow, but sometimes there is a book say that, oh, better 45 degree. It depends. Most of the time, if it's 45 degree in the case who can't really lie down, especially in the case of breast cancer with pleural effusion, they cannot lie down because of breathlessness. So you can put a patient on the 45 degree. But if the patient is okay, no shortness of breath or whatever, you can just lie the patient on one pillow and make sure that put your the patient's hands on the at the back of the head. Okay, then you continue with your palpation. How you palpate is normally, it depends. Whenever whatever type of palpation that you want, horizontally or radially, but use your three finger. You use your three finger and nail. You use the bed. Okay, and then you palpate and don't ever miss 1 cm lump. Okay. You have to be very familiar with the normal breast first in order to identify the abnormal. Okay, but now you already identified that is a 2 by 5 cm. Is, I would say, is quite huge. Anything 5 cm quite big, and then it's a fix when moved vertically. So when it moves vertically, it's fixed. What do you worry?
It's fixed to the chest wall.
You worried of this, the tumor might fix to the chest wall. Okay, so good. And you need to see whether is there any, as you said just now, there's no ulcer, there's nothing. The skin, whether it's attached or not. When you examine, is there any attachment of the skin? I think you don't mention here. Okay, you pinch. It's just really easy. You just pinch on top of the lump and see whether you can pinch or not. If you cannot pinch, it means that it's attached to the skin. Okay?
I see.
Okay, yeah.
Okay.
And then maybe I just would like to add on nipple discharge here is there is no nipple discharge, so it's okay. But how if is, let's say there is a nipple discharge? So if there is a nipple discharge, you have to describe the nipple discharge. What color it is, yeah. So is it a bloody, or is it is serous? You can identify, right, in between bloody and serous or hemoserous, right? So you have to identify the color and how many ducts is involved. When you express, you can see there is is it like one single duct or is it like multiple duct? Okay. And is it like only one breast or is it like both breasts has this nipple discharge? That is just to add on your examination.
Yeah. So about the nipple discharge, right, doctor? So you mentioned what's that called? Hemoserous, serous, and
bloody.
Yeah. So just like to ask about maybe for like in the case of duct ectasia, it will be in any color.
It can be, most of the time it can be greenish, but sometimes it also can present as a serous discharge. Yeah.
I see. Okay.
Very rarely I found bloody lah in duct ectasia.
Okay. So I think that the lymph node axilla examination finds there are no palpable nodes, no overlying skin changes. So doctor, just like to note for example, if in this case there is a supraclavicular fullness, do we need to like wait for that? Because if the axilla don't have any lymph nodes, then why would the supraclavicular area be full?
You will never know, so you should examine. You never know. It might skip, but most of the time it's supposed to start with from axilla and then it goes to supraclavicular. But as I said, there's no shortcut. You examine the axilla and don't forget about the cervical as well. Okay, so you should examine as well, because for example, in infraclavicular, sometimes you won't be able to feel that, and interpectoral nodes, right? So it's at the infraclavicular. So if there is no lymph node in axilla, you don't simply just, okay, I just want to forget about the cervical. We never know. It might skip the axilla, or you don't really feel it, Sometimes it's too deep enough for you to feel it, and then it's already spread to supraclavicular. You never know. So that's why there is no shortcut. So you should do step by step.
Okay.
Okay.
So is there anything you'd like to add before we move on?
Do we finish with the breast?
I think so.
Okay. So as I said just now, after you lie down and examine the breast, the best is always to examine for axilla is by sitting up, because sometimes when you lie down, you might be having difficulty in palpating the axillary lymph node. So I would suggest, even in my clinic as well, I will ask the patient to sit up and I will examine the axilla when the patient sit up. Okay.
Okay. So any other examination that we should do, like palpating the liver or anything else?
Okay. In exam, it should be like focus examination. But in real life, you have to be treat patient as a whole. So in exam, for example, like in long case, if they say, okay, what are the things that you want to examine? Because you don't have much time in exam. So you should focus. As you said, you want to, since the patient is already lie down, before the axillary examination, you should palpate the abdomen. Okay, what are the things that you want to palpate? As you said, you want to check the liver. Okay, and what are the things you want to check?
So Raymond said ascites.
Correct. So you want to check ascites. What else?
He also mentioned bony tenderness at the vertebra.
When you lie down. We are talking. Lie down.
Lie down. Okay. Let me think.
Abdomen. In the abdomen, what else?
Splenomegaly, maybe.
Is it very common to have a splenomegaly in breast cancer?
Not really. No.
So, do you ever heard about Krukenberg? Yeah. So where is the cancer goes to?
So it goes to the ovaries.
Yeah. So you should make sure that there is no ovarian mass. So these are the things that you should examine during the abdomen. So we are talking about focus examination, yeah. So you don't need to do a palpation, auscultation or whatever. We focus on to check on the hepatomegaly, ascites, and ovarian mass. Okay, next. So patient now sit up. So what you want to do?
So
just now you said one of your friend mentioned about bony tenderness.
Yeah.
Correct. So you do a bony tenderness, and as well as, since you already checked on the bony tenderness, you also check on the
lungs.
The lungs. So focus examination for the lung. Are you going to? So what are the examination that you want to do for the lungs itself?
Okay, so maybe just auscultate for crepitations.
Do you normally see I use stethoscope in my breast clinic?
Haven't had the privilege of following.
Okay, anyone. So, but yeah. So basically, you hardly see a surgeon wear a stethoscope, right? So, but yeah. So we do a percussion. Because why? Percussion, you can detect a
mass.
You can take a effusion. The sign will be the stony dullness. So when you percuss, if is any stony dullness, it means that there is a risk of a patient might develop a pro-effusion. Okay, that is how you check. Okay, that is a very focused examination. So I percuss for the pro-effusion and bony tenderness. Then at the same time, I will check for the cervical and supraclavicular. So when the patient sitting up. So then after that, you ask the patient to face towards you, then you continue with your axillary examination. So you complete your examination, breast, and as well as you have to check for the metastatic signs as well. Okay? Mm.
Okay. So we can move on to the next case. Let's just quick. Oh, yeah. Okay, these are the investigations: the blood test, full blood count, renal function test, all the rest, and the radiological test would be ultrasound, chest X-ray, CT scan. Leaving us if uniductal discharge is more likely to be malignant than multiductal.
Correct. Okay, when you had your anatomy just now, right? You can see from the sagittal view, there in the breast, the duct will be continue as a lobule. Anything cancers from the lobule and the duct, terminal lobular duct, you can the bleeding or the discharge or whatever will come into that particular duct. Understand? So that is why if there is a bleeding, okay, there is a bleeding. So if it's a cancer, normally it's just one duct. That's why it's very important to identify: is it like multiple or is it like one duct?
I see.
Okay.
Okay. So just moving on, the sentinel lymph node scintigraphy and the bone scintigraphy. So just like to know, the bone scintigraphy, is it done regularly in UM or not at all?
Okay. Bone scan is one of the. I think before we talk about all this bone scan or whatever, we have to focus on the triple assessment first. I know that you want to do blood investigation, blah blah blah, but this blood investigation we don't normally do unless we think that this patient has need to do surgery or patient has symptoms, metastatic symptom, whatever. If it's we saw a patient in clinic, patient well, otherwise we will continue our investigation by triple assessment, right? So which include your ultrasound and mammogram. Especially in this particular patient, 66-year-old, breast cancer is one of my first differential diagnosis. I should do what? You should, in your investigation, you must put the mammogram and also ultrasound first. Okay? So why is it so important to, before I go to bone scan, we go to basic investigation for breast first, because we are talking about triple assessment. So mammogram and ultrasound. Can I just do ultrasound? I don't want to do mammogram, or I just want to mammogram, I don't want to do ultrasound.
I think not, because mammogram can miss the breast cancer if it's small enough, and ultrasound is operator dependent. Is that the correct answer?
Okay, when we talk about mammogram and ultrasound, any patient with symptoms, okay, any patient with symptoms, for example, like breast lump, you should do ultrasound together. It means that ultrasound, mammogram is a must, okay, so what is the cutting edge? From which, from what year until which year? I mean, how old is the patient that require mammogram? In which?
50 to 70?
50 to 70. So normally we will start at the age of 35.
Oh, okay.
If patient has symptoms, you start at age 35 to do mammogram. If patient has symptoms. But if a patient is symptomatic, it means that there is no lump, nothing, just came for screening, you start at age 40.
I see.
Okay. But in Malaysian screening, guideline, it's supposed to start at 50. So if let's say you have a patient at the age of 40 came to you without symptoms, you said, I want to do mammogram. So you can do mammogram. But if let's say you want to catch one of the patient out there, that to do a screening, you should start at the age of 50. 40, you cannot deny. It means that if a patient wants it, I want a mammogram, even though my age at 40. So you can do a mammogram. It doesn't mean that, cannot, you go home and I have to do at the age of 50. No. Okay, you cannot deny that. Okay, but breast cancer guideline for Malaysia, we start at age 50 for screening. Okay, that's the words that you have to remember. Screening, you have to start at the age 50 and above. But if patient really wants a mammogram, you can start at age 40 and above. But if a patient have symptoms, breast lump or any symptoms, nipple discharge or whatever, you start at the age of 35.
Okay.
Understand, yeah? So that is about mammogram. Haven't said, I haven't described about any for ultrasound. Ultrasound, any age should be okay. Okay, if you had a patient with 20-year-old came with a breast lump, you start with ultrasound first. Okay, you don't start with a mammogram. Okay. So the mammogram is reason behind you do mammogram. You want to check whether this lump is only one particular lump or is it any other microcalcification that can be seen in mammogram that you cannot see in ultrasound. But for ultrasound, why I do ultrasound is for basically for diagnostic purpose and as an adjunct, because I want to know this lump is cystic or solid, is it or is it like semi-solid or is it like mixed, you know? That's why you need a ultrasound as an adjunct to in order to help you in terms of diagnosis. Okay, so in ultrasound you look at all the features of malignancy and you also need to assess your axilla as well. Okay, mammogram and ultrasound. Then you go into you ask about the bone scintigraphy. So normally when you stage a patient, you stage do you stage everybody?
No.
Okay, correct. So if is a patient has a breast cancer stage 1, stage 2, normally you won't stage a patient. You don't do CT staging or whatever. But if a patient is stage 4, stage 3 or stage 4 by clinical, because you don't know, you are going to investigate by clinical assessment. You suddenly feel a lymph node, for example, in the contralateral side. If it's contralateral side, it's already metastasis, right? So it's considered M1. So you should do a CT staging, or it's a stage 4 disease. Stage 4 disease is locally advanced, for example. So you should do a CT staging. And CT staging must be include your lungs, your abdomen, and pelvis. Okay, but from here it doesn't include your bones as well. But CT scan sometimes see the bone metastasis, but it is not sensitive enough to diagnose whether this patient has bone metastasis or not. Okay, so but standard protocol is always CT staging, but some surgeon or some oncologists, they will also ask for bone scan as well. But for me, it depends on the patient's symptoms and is there any other signs from the CT scan, like 50-50, iffy, not sure whether it's MEDS or not MED, then I would consider bone scan. Does it answer your question?
Yeah.
Okay.
Answer my question. So Ui Ingjia asked, Doctor, so breast examination should be done lying 45 degrees or supine?
Okay, when you do a breast examination, supine. But in the condition where I said just now, right, patient cannot lie down. In whatever reason, patient cannot lie down because of breathlessness or because of pain or whatever. Maybe you can, then you can ask the patient to do a 45 degree. Understand?
Okay. So so last question about this case. So what is the what's that called, justification for using FNAC? What is the justification for using a what's that called, a core needle biopsy? What's the
Okay. When to diagnose the breast cancer, you can diagnose using FNAC, fine needle aspiration. You can also diagnose using a core needle biopsy. But what is the advantage and disadvantage of these two type of investigation? Okay, so one thing is when you do fine needle aspiration, definitely you can see the abnormal cell. Okay, atypical cell. You can see ductal carcinoma, you know. But then you can't really differentiate in between in situ and invasive. Because why? because you just only have a cell. Yeah, you only have a cell. So I can see, oh, this cell looks abnormal. So this is cancer cell. Okay, that's it. But I cannot identify whether this is invasive or this is just ductal carcinoma in situ. So that is why most of the time we use you can see in our breast surgery, we do a conidal biopsy.
I see.
Okay, so but when any surgeon or any doctor asks you, can you diagnose breast cancer with FNAC? The answer is yes. You can diagnose, but you cannot differentiate in between in situ and invasive. Okay, because these two things, the management will be different. Okay, and then what is the good of invasive conidal biopsy? One thing is you can have your you can see if invasive CA or not, and you said just now the type of cancer, whether it's lobular or whether it's ductal. Grade of the cancer itself, grade 1, grade 2, grade 3. Okay.
Well differentiated.
Yes, and then you can see the LVI. What is LVI? Lymphovascular invasion. That is one of the prognostic factor. You can see if it's presence or not, you know. And how about the ERPR? Can we get it from the FNAC?
I think so.
Yes, we can get ERPR from fine needle aspiration. In a conidal aspiration also, you can also get definitely you can get the ERPR, but the one that the FNAC cannot provide you is the HER2 status. You know, the HER2 status is only can be used. You can only get it from the conidal biopsy. You cannot get from the fine needle aspiration. Okay. So why is so important about ER, PR, and HER2 status is your diagnostic, is your predictive and prognostic factor. Okay, for your treatment later lah, and your, as I said, predictive and prognostic factor.
Okay, so doctor, Ong Yi-Chen asks, if patient present with breast lump before age of 35, do we do MRI?
Okay, the reason we do MRI, sorry, the reason why we do MRI is, as you said, in young patient, why I so much bother to do MRI, because when you do a mammogram, the breast is so dense. You might miss a single lesion from the mammogram. That's why most of the time, not most of the time, it depends. If it's the mammogram showed is very dense breast, I would request for the MRI. Good question.
So Chunying asks, is sentinel lymph node biopsy considered part of the triplet assessment?
Okay, sentinel lymph node biopsy is not part of the triplet assessment. It's the treatment. It's a form of treatment. Okay, so when you do a sentinel lymph node, so you do during a surgery. Okay, during a surgery, you remove the breast lump or you remove mastectomy together with the sentinel. So the sentinel lymph node is part of your treatment. Okay, surgical treatment. It's not part of the triplet assessment. Okay, don't confuse that. Your triplet assessment is by ultrasound. You check mammogram. You check whether is there any lymph node or not. Okay. And some center, okay, who has a lot of resources, you know, they can, they will do, if let's say they do ultrasound, looks the lymph node suspicious, oh, I want to do a biopsy, suspicious, they will proceed with a biopsy. Not in UM, because it will take some time for us to diagnose and treatment for the patient, because you know, our list is quite long. So that's why we only depends on our clinical judgment, which is examination and also ultrasound and mammogram for the lymph node positivity.
Okay, so Sheikh Hakim, Shaikh, I'm not sure, sorry if I butchered your name. He's asking if mammography sensitivity is determined by breast density. Does that mean older women with higher breast density should go for ultrasound instead of mammogram?
Okay, as I said, mammogram is a must if you want to diagnose a breast cancer, especially a patient age more than 40. Okay, So because in mammogram, you can see all the small lesion, for example, in microcalcification that you cannot see in ultrasound. Patient will tell you, doctor, I don't want to do mammogram, I just want to do ultrasound. Cannot. Because why? You might miss the microcalcification, or you might miss the signs like that you can detect from the mammogram rather than ultrasound. And the features sometimes from the ultrasound show that, oh, very small. But in mammogram, you can see the hypodense lesion is very huge, which is not suitable for breast conserving surgery, for example. So that is why mammogram is a must every each single patient that you are going to diagnose. You are going to investigate for breast cancer.
Okay, so I think this is all for this case. Let's just quickly move on. Next slide.
Mm-hmm.
Next slide. Noreen, hello. Okay. Okay, so for this patient, she was electively admitted to UMMC, and she did a left complete mastectomy plus a sentinel lymph node biopsy. Keep in view left axillary dissection, and IV cefazolin and IV patent blue dye was administered. Okay, so anything you'd like to add? Yeah.
Yeah, the words that you use is not totally wrong. So okay,
Hmm?
you have to mention that it's a left mastectomy lah, or modified radical mastectomy, not left complete mastectomy. Okay, you have to write that mastectomy. Sentinel lymph node. So why do we need a KIV as a dissection? It's very technical issue and very surgical. You need to know that each single sentinel lymph node, if you cannot find during surgery, you have to remove the whole lymph node. Okay. IV cefazolin is just for antibiotic. We are not using IV pattern blue. We inject the pattern blue into where? When you do sentinel lymph node, we normally do inject peritumoral or subareolar, yeah, or intradermal. So it's not IV. IV means intravenous,
Mm-hmm.
Yeah. Okay.
Oh, I see.
We don't
So,
inject intravenously and then the lymph node become blue.
yeah.
It's actually we inject peritumoral, means like this is a tumor, so you
Mm-hmm.
inject around it, or you inject intradermal, or you inject subareolar. So these are the area that whereby your this pattern blue will go towards drain via lymphatic channel towards the lymph node.
I see.
Then we can identify the sentinel lymph node.
Mm. Okay. So, just a last question. I think we are about short of time. So just like to know. So from what I've read is that yeah, there's no such thing as a complete mastectomy.
Mm-hmm.
So there is a simple mastectomy, radical mastectomy, and modified radical mastectomy. Am I right?
Mm-hmm. Yes. Okay. Modified radical mastectomy is actually the words that we use for after, because initial when you had a history before, the history telling that the Hastad did a surgery, he removed the breast together with the pectoralis major. Can you imagine? It's such very extensive surgery.
Mm-hmm.
But when you talk about M modified, then next surgeon do a modified radical mastectomy, showing that the modified radical mastectomy is less morbidity compared to the radical mastectomy, and the survival rate is about the same. So that is why they do modified radical mastectomy. So modified radical mastectomy is what? It's actually they just spare the pectoralis major
Mm-hmm.
and pectoralis minor. Initially, all the pec all together come out, but now the breast tissue with the what we call that, the fascia removed and spared the pectoralis major and pectoralis minor.
Mm-hmm.
Okay, that's why we call it modified radical mastectomy, MRM.
Okay, so I think that should be all for our cases. I have more questions, but we a bit short of time.
Mm-hmm.
I think this we can get actually from the books. I think it's
Mm-hmm.
actually quite extensive enough. Just a few questions for the students. So maybe you can look up what's the pros and cons of conservative breast surgery, like wide local excision versus the mastectomy. what is the indication for radiotherapy and chemotherapy in patients, and TNM staging, and what is the use of TNM staging. So I think that should be all. Anything you'd like to add, doctor?
You want me to explain all these things or what? Or you want to have other session?
I'm not sure if you are free, maybe you can just explain it. If not, we can just call it a day, and maybe we can get you to write down and send it into the group or something lah.
Okay, so I think let me summarize the treatment of since we already talked about investigation, right? And then now we talk about management. So I just simply give you 5 treatment of breast cancer, which is come together as a combo. It's not a la carte. I want mastect. I don't want chemo. It's a mastectomy.
Hello. 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 Hello, doctor. Am I lagging or? Okay. Hello. Can someone answer me if I'm lagging, or is it doctor that is lagging?
You are not lagging.
Oh, so
We
doctor.
can hear you.
Oh, okay. GG. Okay. 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 How? Oh no, doctor lag. So Nurin, can you just message doctor, tell her that her thing is. Oh, okay, doctor is back. Hello. Hello, doctor. Yeah, doctor, just now you got cut off.
Yes.
Yeah.
Who don't want to know about this? Okay, just very simple, basic for you guys, because most of the time we don't in exam we don't really ask you in details, but just remember of these 5 things. Okay, we talk about breast cancer treatment. There is 5 of them. 5 of them. Okay, 1 is surgery, 2 is chemotherapy, radiotherapy, and your hormonal therapy, and last but not least is your targeted therapy. Okay, so breast surgery is very simple. You divide into breast and axilla. So you cannot treat breast and axilla as one thing. You have to treat breast and axilla 2 different things. Okay, so breast either mastect or BCS, breast conserving surgery. So how do you decide on breast conserving surgery? If it's a single lump, okay, and then when you do a surgery, you can have a good margin, and the breast is not distorted. It means like about 20% ratio in between lump and breast. Then you can proceed with breast conserving surgery. Or a patient can come for radiotherapy, because when you talk about breast conserving surgery, you must have radiotherapy. That is one indication for your radiotherapy. I think I answer all in one shot. Yeah. Breast conserving surgery must have radiotherapy in order to get almost similar risk of recurrence with mastectomy. Okay, if patient said I cannot come every day to the hospital for radiotherapy, then forget about breast conserving surgery. Okay, patient must comply on that. Because if patient just do breast conserving surgery, which is white local excision alone without breast radiotherapy, the recurrent rate is very, very high. Okay, so I don't want to have like half-hearted treatment. Okay, you must have breast conserving surgery plus radiotherapy. If a patient cannot do radiotherapy, then forget it. So mastectomy. Okay, so that is about breast. Okay, then how about axilla? Okay, some some students said, if you do mastectomy, you have to do axillary dissection. No, okay, you should divide it into breast and axilla. And how about axilla? You're talking about axillary surgery. 2 things. Is it clinically is it suspicious or non-suspicious? If it's positive or not positive. You see, from the ultrasound showed there is no lymph node suspicious at all, then you go for sentinel lymph node. Okay. If there is suspicious lymph node from the ultrasound, then forget about sentinel lymph node, you do SE dissection. So that is about treatment for breast and axilla. So we go to chemotherapy. What is the indication for chemotherapy? Any patient with bad prognosis, with the bad features of prognosis, for example, lymph node positive. Okay, lymph node positive, triple negative breast cancer, means that ER, PR, HER2, all negative. Okay, or grade 3 cancer, or very young patient. Okay, chemotherapy is a must. Okay, and most of the time I can conclude stage 3 and 4, most of the time they will need stage 3 and a 4 stage 3 patient might need a chemotherapy. Stage 2, in a patient with a lymph node positive, then you have to proceed with a chemotherapy. Okay, radiotherapy, you said just now, whoever that has need to go for breast conserving surgery must have radiotherapy. Whoever had a locally advanced breast cancer, radiotherapy, means that skin involved lah. Yeah, skin involved. Anyone has lymph node involved need to go for radiotherapy. Okay, so I just summarize this, yeah. Mm-hmm. And then hormonal treatment, whoever has estrogen receptor positive must have the hormonal treatment. Whoever has only ER was negative, PR negative, HER2 negative, ER negative, you don't normally give hormonal treatment. Okay, and last but not least, your targeted therapy, which is nowadays is we do have this targeted therapy. Whoever had HER2 positive, then you might consider a trastuzumab or HER2, Herceptin, the other name. Okay, so that is how I conclude my treatment for breast cancer.
Okay, so I think that is all for the case. One last question. Last one. So yes. For Lim Sanhua asked, for breast cancer screening, who will be considered as a high-risk group and what screening test should be offered?
Okay. High-risk patient is whoever, you remember 3 to 1. This is when you talk about high-risk patient, 3 to 1, it means that anyone in the family members, first degree or second degree relative, has 3 of them has breast cancer or ovarian cancer. Mm-hmm. How about 2? 2 is anyone with breast cancer less than the age of 50. Okay. 1 is anyone with the breast cancer, ovarian cancer in the family. I'm talking about family. Ovarian cancer, bilateral breast cancer, male breast cancer. That is all the patient that require high risk screening lah. Mm-hmm. Okay, high risk screening means all this. Okay, you can start at the age of 40. When we start at age of 50 is the normal population who has no family history of breast cancer. The best screening method is always 2-view mammogram, MLO view and CC view. But nowadays they have tomo lah, all these things is advantage with our current mammogram machine.
Okay. Okay, I think that should be all. So thank you, Dr. Suniza, for willing
to
come and talk to us about breast cancer.
Sure.
Thanks everyone for attending. So hope to see you again, Dr. Suniza.
Sure, if I'm free. Okay?
Sure. Okay.
Thank you very much.
Okay, thank you.
Okay, bye.
Bye,
Stay safe, huh?
Yeah. COVID. Okay, bye. Thank you.